Good afternoon, and welcome to the Grand Rounds educational series. The Greenberg Bladder Cancer Team is grateful that you are here. I am Karen Sachse. I'm stepping in for Stephanie, who is away to moderate today's session. I have been a little bit about me. I've been an oncology nurse for over 40 years. And I'm currently working as a nurse navigator for the Inova Peterson Life with Cancer program here in Northern Virginia. I'm also an active patient advocate for the Bladder Cancer Advocacy Network. Today's session is near and dear to my heart because 15 years ago, I was diagnosed with high-grade non-muscle invasive bladder cancer. And when BCG failed me, there were very few alternatives. Luckily, one of them worked for me. So it's really an honor to be with you today. For the past decade, the team at the Greenberg Bladder Cancer Institute has been working on building the most comprehensive platform for educating our community. And it's really a pleasure to be with you here today. But first, before we get into the content, I want to give you a couple of updates and maybe a few reminders. For the most current information about the Institute, you can just simply Google Greenberg Bladder Cancer Institute. They are always expanding their educational offerings, including the growing collection of programming for women only with bladder cancer, led by Doctors Armin Smith and Jeannie Hoffman-Sensitz at the Sibley Memorial Hospital in Washington, D.C. And that program is specifically tailored around the experiences of women with bladder cancer. And you can get all the information about the upcoming programs that they offer on the website. And additionally, in order to provide easy access to care, I will, once we get started, put in the information, but the email addresses to take note of are bladdercancer@jhmi.edu, and there is a more specific email for patients with upper tract urothelial cancer, utuc@jhmi.edu. The other thing that I wanted to mention is that there is a brand new resource called the Greenberg Bladder Cancer Institute checklist. And it is a series of carefully developed insights and important questions that they believe all patients should be asking and have on hand to take to their providers and at their office visits. And that is loaded on the GBCI website. You can also stay up to date with the most recent newsletters and take a look at the portfolio of the dozens of previously held Grand Round sessions, which is one of the really great things about these programs is they are recorded and then on the website for you to view at your convenience. This afternoon, I'm excited to welcome Dr. Max Cates for a discussion on BCG and promising new alternatives. Given all the supply chain issues that we've all been experiencing and what are some of the alternatives we should be aware of, Dr. Cates is an expert resource in this space for us. But let me give you a few more details about Dr. Cates. He is the R. Christian B. Evanson Professor and Associate Professor of Urology and Oncology at the Brady Urologic Institute at the Johns Hopkins. He also directs the Division of Urologic Oncology for the Brady Urologic Institute. He completed his undergraduate degree at Wesleyan University in Connecticut before going on for his medical degree at Mount Sinai School of Medicine in New York. He then went on to train at Johns Hopkins for his urologic residency and a fellowship with Society of Urologic Oncology. Dr. Cates has expertise in all areas of urologic oncology with a particular emphasis on bladder and prostate cancer, with training in open, endoscopic, and robotic surgical approaches. Dr. Cates' surgical philosophy is to assess the unique needs of each patient and develop the right treatment plan for their cancer. He is very hands-on in his approach in the clinic and in the operating room, and believes open communication with the patient's family, and referring providers is key to a speedy recovery. As the clinical director of the Bladder Cancer Multidisciplinary Clinic, Dr. Cates works with the team at Johns Hopkins Greenberg Bladder Cancer Institute to develop a personalized approach to bladder cancer utilizing cutting-edge precision and medicine approaches. So, Dr. Cates is going to give a brief talk entitled, "What's Up with BCG and Other Treatment Options?" And then while there are many questions, I have a few myself, but please put them in the Q&A function at the bottom. Okay, Dr. Cates.
Hello, everybody. Can I get requests to show my face? I know it's not that beautiful of a face, but I'll show it anyway. There we go. This is a great group. Okay, so we have about 30 attendees. We have 6 more that are sort of panelists. So we got a nice group for a Q&A. I'm not using slides, so we're making this kind of old school, because what I really want to do is walk everybody through the latest and greatest in BCG alternatives, I'll say, sort of drugs and approaches to managing non-muscle invasive bladder cancer other than BCG. I'll talk about what's both FDA approved, and then I'll talk about what I think is coming. That's basically already received, already sort of completing their pivotal clinical trials, or soon to be completing their pivotal clinical trials, and maybe FDA approved. And then we'll really go into some Q&A. So without further ado, let's just talk about, let's like level set, and what are we talking about? So bladder cancer, this is going to be repeat information for probably 80%, but for the 20% that it's not, I'm going to repeat it. Bladder cancer does not follow the traditional staging that you grew up with of stage 1, 2, 3, 4. It sort of does, but no patients and no urologists or medical oncologists really sort of use that nomenclature. Instead, we really refer to it as non-muscle invasive bladder cancer, muscle invasive bladder cancer, and basically then locally advanced or metastatic bladder cancer. So for non-muscle invasive bladder cancer, right at the outset, the majority of patients want to preserve their bladder and can preserve their bladder. What do I mean by that? So these are by definition tumors that do not invade the muscle wall. They're superficial. And so typically the management is scraping out that tumor with something called a TURBT, and then bringing them back to clinic for a wash of medication through via a catheter that's inserted into the bladder once a week for 6 weeks. And that drug, since the late 70s, has been BCG, which is an inactivated form of tuberculosis. Oh my gosh, you could say, why are we giving inactivated tuberculosis vaccine, I should say, tuberculosis vaccine? Why are we giving that to bladder cancer patients? Well, it was observed that patients who had active tuberculosis may have had less bladder cancer. So just like sort of based on that observation, it ultimately led to Morales, Al Morales and colleagues in 1976 testing BCG delivered as a wash in the bladder once a week for 6 weeks. Why 6 installations? Well, the package insert came with 6 vials. Believe it or not, that was the reason. So this was kind of before we really practiced what I would call evidence-based medicine, and a lot of it was kind of, we didn't know any better, but nevertheless, it was shown to work, and really since 1976, it's been the standard of care. That's almost 50 years. There's 2 problems, though. Number 1, I would say actually 3 problems with BCG. The third is the biggest, but number 1, it does have some significant toxicities for some patients. That includes urinary frequency and urgency, and then actually some systemic side effects, which can result occasionally in hospitalizations. Number 2, it doesn't work perfectly. It works okay, but it still has room for improvement. I would typically quote patients about a 75% chance of no cancer at 1 year. So about 25% chance the cancer comes back at 1 year, maybe 40% chance the cancer comes back at 2 years. So it's okay, but it's not. Obviously, there's room for improvement. The third is the biggest problem, and that it's incredibly difficult to make and requires a lot of investment. And it's a generic drug. And the fact is the United States has not invested in it. And the companies have not invested in it. And so we've had rolling drug shortages for the last, really for the last decade and a half, but it's been accentuated since 2019. We've really been in a rolling shortage since 2019. There's really only one form of BCG that's available in the United States. There's many different strains of BCG elsewhere in Europe and Asia, but in the United States, it's only Merck's Tice strain, and they're building another factory, but still it's on shortage. So both when patients have recurrences to after BCG and for patients who don't have access to BCG, what options do they have? And so I'll speak to that. I think first, I'll speak to patients who need an alternative to BCG. So when it's not available. And that's really talking about, well, what do we know about newly diagnosed high-grade non-muscle invasive bladder cancer patients and what drugs work? So really the main alternative right now used in the United States is a drug combination called gemcitabine and docetaxel, or gemdosi. It's 2 chemotherapies that are given sequentially. Originally started in around 2010 by a guy named Mike O'Donnell at University of Iowa. It's now widely used across the United States. And at Hopkins, during the BCG shortage, this one, we enrolled 25 patients in a clinical trial and showed that the 1-year response rate was around 92%. So very promising. Based on that, we have a randomized trial that we're leading at Hopkins, but it's a trial open at 70 centers, 870 patients, and it's being randomized between BCG and gemdosi for newly diagnosed bladder cancer patients. And so we're very comfortable telling patients that in the absence of BCG, gemdosi has data to support it as an alternative. It does not have data to support that it's equal to or better than BCG. So right now, I'm only comfortable using it in patients where there's no BCG available and a BCG shortage, or after they recur after having BCG. But hopefully the results of the clinical trial will be able to allow me to tell patients that it's equivalent to BCG in the future. So that's gemdosi. Very quickly, there are other clinical trials that have started to report out that are evaluating immune checkpoint inhibitors. These are systemic immunotherapies given with BCG to show that they may be better than BCG alone. However, there's two issues. Number one, they're not FDA approved yet. And even if they get FDA approved, it looks like they only improve the 1-year response rate, for example, by single digits, and they increase the toxicities by double digits, by 10 to 13%. So it may not be worth it to add on the immune checkpoint inhibitor for most patients, but for very high risk patients, we may do it. And it doesn't help us with the BCG shortage because these immune checkpoint inhibitors are given with BCG as a combination therapy. So that's just something I wanted to mention. If it comes up in Q&A, we can talk about it more. All right, let's move on. So we've talked a little bit about what to do in the setting of a BCG shortage. But what about when somebody recurs after receiving BCG? Well, this is a whole different bag of worms. And this is really where it's starting to be pretty necessary to seek care at a specialized center that has focused specialization in bladder cancer. Why? Because whereas 10 to 15 years ago, really our only option was removal of the bladder, or maybe a clinical trial, or maybe a wash of single agent chemotherapy that we knew didn't work very well. Now, there are several options, and it really takes a specialized approach with patients to figure out what's the best option for them. So I'll give you an example. A 77-year-old man that comes in with a recurrent tumor after BCG, comes in and sees you, says to you, I recurred, I don't know what my options are. First question I will then ask is, what's your life like with the bladder that you have? Okay. Why am I asking that question? I'm asking that question because I'm trying to figure out, is this a bladder worth saving? So if he says, well, you know what, I'm getting up 4, 5, 6 times a night. I'm urinating every 30 minutes. And you know what? I'm going through 3 or 4 pads a day. I'm incontinent. Well, then I'll say, with all due respect, sir, what are we doing here? If we give you more treatment and you continue to have tumors, your symptoms will only worsen. And it sounds like your quality of life with your bladder is not so great. So clearly that's why our AUA guidelines recommend discussion of bladder removal or radical cystectomy at this point when a tumor has recurred. And that's why I will start to probe the patient to try to understand what's their current quality of life. But many patients do not have those symptoms and are very pleased with their bladder and would like to keep it. And so that's where our second line options come in. I already mentioned one of the options, that's gemdosi, and that's oftentimes what I will turn to. But there are currently 3 other options that I discuss with patients. Actually, well, a fourth, which is clinical trials, but 3 other FDA-approved options. One of them is a drug that I am not typically recommending for my patients with this disease state, and that's single agent. So that means just the drug alone of infusions of pembrolizumab, which is Keytruda. That's an immunotherapy. At this stage, right after they recur with BCG, the data with Keytruda or pembrolizumab suggests that it has about a 19% response rate at 1 year and about a 13% risk of an autoimmune side effect, getting hospitalized for an autoimmune side effect. So that's like almost an equal risk of it working and getting a bad toxicity. I think for most patients, they're not going to really go for that when they hear that. But I talk about it. There are 2 intravesical therapies. So intravesical means given through a catheter in the bladder. And they're very different. One of them is called adstiladrin. We've had it at Hopkins for about 6, 7 months at this point. I mean, actually, maybe longer. We've had about 1.5 years, I should say. It is basically a gene therapy given as a wash through a catheter The nice thing about it is that it's only given quarterly. So patients who live in Southern Maryland or West Virginia, or even fly in from Florida, they can come in once every 3 months. The problem is it doesn't work particularly well. So there's about a 23-24% chance of having no recurrences within a year. So the likelihood is that the cancer will come back. Unlike Keytruda or pembrolizumab, it's unlikely they will have a bad toxicity. So I can say it's relatively safe, because it very much is. It only needs to be given quarterly, but the risk of recurrence is quite high. The risk of progression to muscle invasive bladder cancer is actually quite low. So because of that, a lot of my patients, especially those who have a hard time coming in to clinic, will go for that. The other option is a drug called Anktiva, which is a immuno super agonist that basically revs up your immune system. Unfortunately, it's given with BCG, so it really doesn't help the BCG shortage very much, although the company's working on getting alternative forms of BCG into the United States to be paired with it. But it looks like it has an efficacy of at 1 year around 40%, so much higher than is reported with for example, the Keytruda or the pembrolizumab. It may be better than the Adstiladrin, but very tough to compare, because all of these studies were done as what's called single arm trials, which means there was no comparator arm. All patients got the drug. They weren't placebo controlled, which is great. I don't believe that's ethical, but they weren't controlled with anything. So we have no idea what to compare it to. So that's a problem when trying to compare these drugs. But that drug we should have at Hopkins within the next month or two. A lot of these patients will still go on to a clinical trial, and we have many clinical trials open at any given point still for this disease state. There are 2 other drugs that may be approved within the next year that are very interesting. I'll just briefly mention them. One is by a company called CG Oncology, and cretostimogene is the name of the drug. And again, basically, it's a sort of more thoughtful way to rev up the immune system to fight the cancer, the bladder cancer. Its data is still kind of maturing, but it appears that it's going to have very favorable 1 year response rates compared to some of the other drugs I mentioned. So we'll see. And then the other drug is a drug called TAR-200, which is a chemotherapy called gemcitabine that I already mentioned as part of Gemdosi, but it's given as sort of a depot release through a silicone ring that's implanted in the bladder and just floats around the bladder and delivers the gemcitabine over weeks and then is switched out. So that might be very interesting as well. So I'm going to kind of stop there. I've been talking sort of at you for about 15 minutes. But as you can see, the landscape of alternatives to BCG is quite robust. And I always tell my residents who are considering a fellowship in oncology, the question of why should they get a fellowship in oncology, 10 years ago, maybe it was a complicated choice. But today, bladder cancer has 5 new drugs in the metastatic space, in the early space. There's just a lot of information to learn. And for you as the doctor to know it is a task, and then to be able to parse it down so that you can communicate it effectively to help patients make a decision is an even bigger task. And so for that reason, I think at the point of recurrence after BCG, we're increasingly seeing referrals to specialized centers. I'm going to leave it there. Karen, do you want to come back online and help guide me through questions in any way? I don't know what kinds of things people want to talk about.
Okay. Well, the first question, you talking about the specialized centers. And of course, I know that, Johns Hopkins, is a specialized center, but some of our listeners, don't live with Johns Hopkins in their backyard. How would they go about finding a center?
It's such a good question. So, I mean, I would answer that in a couple of different ways. Okay. There are national Comprehensive Cancer Network centers. Okay, there are NCI designated centers. Any of those should have a bladder cancer a urologist, basically, a urologist that sees mostly bladder cancer. But even in large private groups, there's large groups now in many different states. I would say any urology practice that has more than 20 urologists, of which there are many, usually has somebody that kind of subspecializes in bladder cancer. And you may just ask if you're as part of a big private group, hey, is there somebody in your group that does most of the bladder cancer? Could I have an opinion, a consultation with them? That's always very reasonable. But I would say those are two great resources, the NCCN, National Comprehensive Cancer Network, and then the NCI as a way to find, experts.
FYI, on the Bladder Cancer Advocacy Network on the BCAN website, there's actually a map that shows the NCI designated centers. So that's available too.
I should have put that question back to you, Karen.
That's okay. Anyway, we've been talking about all these different treatments, and are these treatments for patients with high-grade disease, low-grade disease? I'm wondering if you could talk a little bit about the difference between those and, what kind of diagnostic testing is done to determine low-grade versus high-grade.
Yeah, and there was a question in the Q&A sort of kind of related to this about low grade. So it's a great question. So everything I just talked about was really geared towards high risk non-muscle invasive bladder cancer, which is primarily high grade non-muscle invasive bladder cancer. Why did I gear it towards that? I geared it towards that because that's typically where we give BCG. We do not typically give BCG for low-grade cancer, although there is good data to support it for recurrent low-grade cancer simply because we're in a severe shortage. And so the AUA, the American Urological Association, has come out with a statement recommending we do not give it for recurrent low-grade bladder cancer. We typically will do other things, but there is so much excitement right now in recurrent low-grade cancer for patients. There is a FDA meeting tomorrow that actually I will be a part of, for what's called an AdCom, for the advisory committee meeting for a drug called UGN 102. And that is the idea of giving an intravesical installation of, in this case, a re-engineered chemotherapy that's a gel that then forms a liquid to ablate a tumor. So the tumor is still there. It has not been scraped out. And it's given to ablate the tumor. Why? Well, it's for patients with recurrent low-grade tumors. So they, by definition, have had multiple TURBTs, and it's to try to break that cycle of TURBTs and do something different for patients, give them a medical option instead of surgery. So that is going to be tomorrow at the FDA, and it's a public hearing. You're welcome to take a look at that. And then there's also other late clinical trials for recurrent low-grade disease too. So I didn't really touch on that, but yeah, what I'm talking about with BCG, mostly we're now focusing on giving it for high-grade disease.
It's a question about surveillance and the role of some of these urine tests in surveillance. And could you make a comment about that?
Yeah, so Cxbladder is essentially a urine panel, RNA-based panel. It is used in my practice. There's some interesting studies on using it as a way, especially in recurrent low-grade patients, as a way to maybe avoid cystoscopies. So instead of doing the cystoscopies every 3 months, maybe you can do it every 6 months and do a Cxbladder test in between. We use it especially when a urine cytology is equivocal. So maybe the urine cytology says suspicious for high-grade cancer, but it doesn't say definitive, and we want another urine test to kind of help us. those are the situations which I'll use CX bladder. There's a whole other host of really exciting urine tests that are coming down the line related to identifying DNA in the urine, so tumor DNA in the urine as a means to monitor and detect bladder cancer in the urine. And I'm really excited about where that's heading. Still not super ready for prime time, those in my opinion, but more to come on that.
Great. There's a question that actually I wanted to ask about on the bridge trial that you talked about, that you're comparing, BCG versus gemcitabine docetaxel. It it looks to me that the length of treatment is different for the different arms. So I wanted to ask you about that. And then it kind of relates to some of the side effects that patients have with BCG and, the irritation on their bladders.
Yeah, it's a great question. So whenever you design a clinical trial, you really can only use what's been done before, especially when you're at the latest stage of a trial, which is where you compare one drug to another. So what has been published before is the standard of care with BCG is giving an induction course and then giving 3 years of maintenance. And that's been shown to be the best from a cancer standpoint. With Gemdosi, the standard of care is giving that induction course and then 2 years of maintenance treatment. So in comparing the two drugs, we just compare the two standard of care. Now, is there a chance we may find a great deal of recurrences between years 2 and 3? There's that chance. I think it's pretty low. But if we do, then it could be explained by the different maintenance regimens. But I think most of us are very comfortable with the 2 years for Gemdosi and the 3 years for BCG. But it does speak to the toxicity of BCG, which is quite simply that more than half of my patients, for one reason or another, really don't make it to 3 years, despite complete responses. So they'll have a complete response, but they'll not get 3 years of BCG because of the side effects. And so and I tell them that because they feel bad about it. They're like, oh, I can make it. I can do one more. And I'm like, look, like more than half my patients don't make it. So don't feel bad. Like the additive toxicity is real. So the toxicity that you experience in your first induction is not the same toxicity you experience on your 18th installation with your, third year of treatment. It's additive. So you have to tell patients that so they know to kind of expect it. So they're not downtrodden when they're coming off treatment, despite having no cancer recurrence.
There's a question about, you mentioned other forms of BCG, and the one that we have here is, the one by Merck. What is the process of, getting FDA approval for, some of the other BCG that's made in other countries?
Yeah, it's a great question. So it's considered a biologic, BCG. And every strain of BCG is considered a unique entity. So you can't get approved for just BCG. You get approved for the strain. The FDA has historically, and this is something that many of us are advocating to the FDA to change, but they've historically approved only strains. And that's kind of an issue because a lot of these strains are generic again. So there's not the money to do a whole FDA approval process for each strain. However, there may be some movement on that. There's a company I mentioned called Immunity Bio that has a drug that was FDA approved called Anktiva that has a special program for BCG out of India, and this was mentioned in one of the questions. We're starting that program here at Hopkins. We're interested in it, but that's not going to really address the BCG shortage on a wide level. That's I think relatively niche and really it's probably only going to be taken advantage of by large centers like us. So I don't think it's going to move the needle for the average patient in America.
There's some other questions about, again, about kind of surveillance and the differences between like what's cytology, what information do you gain from that, and what about this fish test, urine test?
Oh yeah, let's go after both of these questions. So because they're different. So urine cytology, what is urine cytology? So I don't mean to toot my own horn, but I'm gonna just do it anyway. Oh, come on. I want to put in the chat. I need to be dynamic in these sessions. We'll see. While I'm at some point while you're asking a question, I'm gonna put in as a link a YouTube that I did with BCAN called "What They Can See in My Pee." It's literally everything you've ever wanted to know about urine cytology. You're going to be overwhelmed by the content. You're never going to want to think about urine again, I'm sure. But basically, urine cytology is taking urine, putting it under a glass slide, and then a really experienced pathologist goes hunting for cancer cells. So you can imagine that by definition is not going to be a great test nationally, but maybe a pretty good test at a specialized center. And that's indeed what we see. So I have a pathologist, cytopathologist, they're called cytopathologists, so they're really specialized, who, I've been working with more than 10 years, Chris Vandenbush. So, he, if I have a question about cytology, I'll ask him about it, and it's pretty good. Now, even our group will make calls that I can't really interpret, such as suspicious for high-grade cancer cells. That is not positive for cancer cells. So if it's high-grade cancer cells found in the urine, usually there's high-grade cancer somewhere. Not always, but most of the time. But suspicious, it's about a 50-50 shot. So we get into that in the YouTube that I'll link. FISH is very different. FISH is not a test I recommend. It's not a test I order. I do not view it as accurate, but patients often will come in with FISH tests. And it's a very old test that looks at basically mutations, DNA mutations in the urine. And for various reasons, it's not reliable and not used by most experienced bladder cancer urologists. Yeah.
So there's the next question is about high grade, a woman with high grade disease, and asking the question about, she's asking, what is the best resolution for women for bladder removal? And I don't know if she's asking what diversion is best for women with bladder removal, and I'm going to say that's very individual.
Yeah, I think maybe I'll rephrase the question so it's a little more generalizable, if that's okay, Karen, and just
Yeah,
talk about how do I talk to women about is my conversation about BCG unresponsive bladder cancer different than it is with men? That's a really interesting question. I would say largely it's not. It's not different fundamentally, but I certainly will probe the urinary questions a little bit differently. Both men and women, for example, experience urinary incontinence, but women have more stress urinary incontinence, especially after after being pregnant and delivering a baby than men. Men do have stress urinary incontinence, but it would typically be from a urologic procedure. So it's slight differences like that. But generally speaking, the question of what's your bladder like? Are you happy with it? Do you want to keep it? Like those conversations would be the same between men and women. The surgical options, are the same. How we talk about organ preservation is a little different. So in women, I'm very focused on understanding sexual function. and understanding whether whether vaginal sparing is going to be a priority. And then I also talk about ovarian cancer with my women patients. We're learning that most ovarian cancer originates in the fallopian tubes. And so I will almost always remove fallopian tubes in women at the time of radical cystectomy. And occasionally I will also remove ovaries. Um, uh, uh, but that's on a case-by-case basis. So that's some of the nuances of maybe how the conversation with a woman is different from a man. I definitely have women call women and men call men who are considering surgery, because I do believe the recovery and the perspective is just a little different. So I've learned from talking to patients that's helpful.
We could circle back to the bridge trial. Okay. One of the things that in some of the write-ups that I've seen about the bridge trial, there's mention of some quality of life indicators, and also some evaluation of the participants in terms of whether there are any indications or any indicators that could lead you down the road to determine who would benefit from which therapy.
Yeah, so there's a couple aspects to that. The first is that we have arguably the most robust patient-reported outcome plan ever done in a bladder cancer trial like this. So we're capturing several different qualitative measures of bladder symptoms and the like, and doing it regularly throughout the trial. Actually, the way it's funded, the way sites are funded, is almost a third of sites funding per patient is for capturing the PRO data. So all those sites are really incentivized to rigorously sort of keep track of that. So we'll have that. That will be incredibly helpful, because you're exactly right. If we succeed in showing non-inferiority between BCG and Gemdosi, the next question is, okay, well, like, if they're the same, which one do I take, doctor? And so the PRO data will help for that. And then we have another side of that, which is that I'll just call biomarker strategies, which is looking at the tissue and other means to try to predict who will respond to one drug versus the other. And we also will have that, readily sort of baked into the trial as well. So both of those things I think will be incredibly insightful, especially if we meet our endpoint. So if we show what we think we're going to show, because remember, we're not trying to show that Gemdosi is better than BCG. We're just trying to show that it's an alternative, particularly in a time of shortage. So it's designed as what's called a non-inferiority study. So if we succeed, we're kind of left with this great thing. We have another option for patients, but sort of by definition, patients will have a choice that they'll want to know, okay, well, like, what do I do now? So it will be important to have those answers.
The other thing that I get asked a lot by my patients that are on BCG, one of the strategies to address the shortage has been partial dosing. Can you talk about some of the data, some of the outcomes for that?
Yeah, so that's a strategy that we've employed at Hopkins since 2019, which is 1/3 dosing. There's a lot of data at this point. MD Anderson's paper is cited often, but we show it as well. That 1/3 BCG appears to do the same as full dose. What's the reason for that? Well, BCG is not really like dosed the way other drugs are dosed. It's just like the amount of spore particles, and we're in like the billion range, or maybe even more. I'm not 100% sure. But there's good data to show that vial to vial, the amount of spores is different. So even like full strength BCG is not like the same amount in each vial, which is a little bit crazy. So basically, the data shows that a third of a vial is enough to get the immune system revved up, and that's basically all you need.
Sorry, couldn't get off mute fast enough. Great. Um, Another question about, the DNA test, the urine test that you mentioned, will they replace urine cytology?
Oh, I hope so. Because I think unfortunately, while I praised urine cytology at certain institutions, it's an incredibly confusing test. Um, my preference is always for a test that's zero or something. A great example would be a PSA after the prostate is removed. I always tell patients with prostate cancer, a PSA is a horrible test until the prostate's removed. And then the PSA is like this amazing test because it should be zero. Or if it's something, then you have to do something about it, or you have to start thinking about doing something about it. So I would love to see a test where there's not an equivocal sort of, we don't know what to do with this answer range. And if you look at most tests, unfortunately, they're like, this is nothing, this is something. And then like typically 40% of patients will be in this like, ooh, we're not so sure range, which by definition, to me, that means it's a horrible test because that is not a great conversation to have with somebody. The I'm not sure what to do with this answer. So yes, I would love the urine CT the urine tumor DNA circuit the urine tumor DNA tests to get good enough to where they both replaced cytology and they have a very small portion of patients where the tests are sort of wishy-washy.
And replace cystoscopy?
Absolutely. I would love to see it replace cystoscopy. And I think we'll eventually get there. Absolutely. I don't think that's tomorrow, but I think eventually, why not? I mean, it makes total sense that tumor cells are shed into the urine and we should pick them up. I think that will be a trial that we would at Hopkins love to lead eventually. That's practice changing, right? But we have to see, before we get there and prove out that it can be done on humans, we have to make sure that the principles are ethical, that the tests are good enough, and that there's really a plausible benefit to those patients going on that study. So I don't think it's going to happen tomorrow, but I do think it's coming.
There's a question back to Gem Dosey. After 2 years, there's a patient that had a recurrence and is wondering about kind of, is there any data on long-term use of Gemdosi, like kind of on a maintenance monthly basis, more like, BCG?
Yeah, anecdotally, I don't believe that there's a lot of toxicity associated with long-term repeat use. But again, we don't know. We don't have great data to support that. We know that it does not have a lot of systemic absorption. So there have been studies where you give it in the bladder and then you do very specified blood tests, like at 1, 2, 6, 8 hours and 24 hours after, and you measure, whether there's chemo in the blood, even at a microscopic level, and there's not. So, I don't. That's a long-winded way to say we don't have perfect data for that answer, but I can reasonably counsel a patient that, I don't think there's going to be long-term added toxicity.
Come up with this combination, Gemdosi and docetaxel.
Yeah, I mean, I think what's the
Gemcitabine,
question about?
docetaxel. It
Like
just,
why or
yeah,
like
yeah,
what's
yeah,
yeah.
yeah.
Again, like a lot of the answers to these questions are not themselves evidence-based. They're circuitous. It's like these are two generic drugs. By the way, we haven't even talked about cost. Gemcitabine and docetaxel is maybe $110 a dose. And that's compared to some of these other drugs, which cover your ears, listeners. can be up to $25,000 a dose. So, there's a real issue with cost. So I think probably the reason they were tried is because they were cheap, they work, and let's see how it does in the bladder, honestly. And then it turned out, like, hey, it does pretty well. So that's the honest answer, but I would pivot to talk a little bit about cost in that, um, at some point we have to start looking at the cost of all these agents and the cost of care, because I do anticipate that if patients don't feel the cost of these drugs now, and many are starting to, at some point, even a 5% copay is prohibitive for many patients if the cost of care is, say $600,000 a year. So, that is an issue as well.
Do you deal much with patients that, don't have coverage? What do you do in those situations?
Yeah, of course we do. I mean, we live in the United States. We don't have a universal healthcare system. At Hopkins, one of my favorite things about being at Johns Hopkins is that in the same clinic, I'll have an incredibly well-off person fly in internationally right next to somebody who's homeless in Baltimore, and I pride our practice on that we. That it's a calling and that we're caring for everyone, and that's our mission. But it's incredibly challenging and difficult when people don't have insurance, and in the face of a lot of these high cost drugs, even emergency sort of, even trying to get them emergency coverage is a challenge. And so that does, in all honesty, change the conversation of what I'm able to offer patients. And it's difficult. Having said that, it is nice that right now we do have options that are relatively low cost in BCG and Gemdosi. So it is not the scenario that somebody's only option is a high cost option. So that's sort of the glass half full.
And could you talk a little bit about, I know some patients are very reluctant to go outside of their own, community practice. And, what is your recommendation as far as, getting to one of these specialty centers?
There's a couple reasons why people don't want to come to a specialty center. One of them is that they're worried about sort of offending their home urologist, a lot of whom they may have known for many years. I find that most of the time, because I always email the urologist, sort of that they came and saw me and my recommendations. That urologist loves that. I mean, they're like, they love talking to me. Sometimes they'll say, "Hey, can we follow up on the phone? Like, I'd love to talk to you about," because they don't know what to do oftentimes. So it's not, it's very rare that somebody's insulted by a second opinion about this topic. This is a very challenging topic. So I'll say that. Then there's the issue about distance traveled. And there's certain distance traveled that's really far. But everybody has their own idea of what's really far. I have patients from the same town. One of whom says it's no big deal. The other whom says this is prohibitive. So, it's like, it's hard to speak to that.
It's all
But
relative.
it's all relative. Everybody's a little different. So we try to work with people where they're at, honestly.
Great. Let's see. One other question was about, at least that I have a lot from patients, is they don't understand what's meaning by the different stages of clinical trials, phase
Ah,
1, phase 2, phase 3. Could you kind of talk a little bit about that?
yeah, this is a really important distinction. So typically, and we have all forms of trials open at Hopkins. And if somebody, and I'll just address one question that I get, which is like, why would you open a phase 1 trial? But phase 1 trials are trials that are oftentimes first in human, and they're evaluating toxicity. So they want to know if the drug's going to hurt people, and they're looking at a signal for effectiveness. We do bring those trials on in my group. Typically, they're not first in human for bladder cancer, they're first as intravesical routes. So we oftentimes know that the drug works. And not only do we know it works, we know it works for, say, metastatic bladder cancer or other cancers, but it's the first time going in the bladder. So it's called a phase 1. And we do bring those on, and usually we'll bring those on because we're really excited about the mechanism of action, the science behind the drug, and that it has a high chance of working on bladder cancer cells. But that's a phase 1 trial. Phase 2 trial is also typically single arm, so it's not randomized to anything. All patients are getting the drug, and it's typically looking for effectiveness, but typically not for registration with the FDA, just to show effectiveness to justify patients ethically being able to be randomized. Why do that? Why does that justification need to happen? Because say you do the phase 3 trial, which is a randomized controlled trial, where say you have 400 patients, 200 get your experimental drug, 200 patients get the standard of care controlled drug. You want to make sure that the patients getting your experimental drug are at least batting close to where the standard of care drug is. So that's the point of the phase 2 trial, because if they're not near there, it's not going to justify ethically randomizing them to the standard of care, if that makes sense. And ideally, you want to show that actually it's promising, probably will be better than the standard of care. So that's the basic 3 phases of clinical trials.
There's another question about BCG and what is the risk of recurrence at 2 years?
Yeah. So the risk of recurrence BCG at 2 years is somewhere around 40% risk of recurrence, 60% of a response to BCG at 2 years.
There is a question about, how do you go about getting a second opinion, in particular at Johns Hopkins? Does that need to be in person? Can it be virtual?
Yeah, I would love it to be virtual. Unfortunately, your legislators do not. And so right now, medical licenses are state by state. So unfortunately, it needs to be in the state of Maryland. And I also find it incredibly helpful for the first visit to be in person so I can examine the patient, really see what their functional status is. Are they coming in a wheelchair? Are they vibrant? Or, are they coming, super active? Are they going to be able to withhold the surgery? What scars do they have on their abdomen from prior surgeries? And is that going to complicate our discussion? So I find it helpful to have the first visit be in person, but the larger problem is really a political problem, which is that we're not legally, or we don't have licenses to be able to do virtual appointments state by state in other states.
And can you talk a little bit about the difference between a second opinion for pathology and like a full second opinion?
Oh, got it. Yeah. So a second opinion for pathology is something that's often done. There's a second opinion service that's provided by our pathologists, and that's to confirm the pathologic diagnosis, to make sure that the pathologic diagnosis agrees with the local center, And sometimes it does not. Oftentimes it does, but it's a good idea. At Hopkins is one of a few institutions that has a really robust pathology second opinion service. That's very different from sort of a second opinion in general, which is where you're seeking recommendations on management, which is going to be with a clinician. And so that's more of what you would see somebody like myself for. Yeah.
I think that's all the time we have.
And we're at 5 o'clock. Man, we really
Yeah.
got here.
Yeah. Well, thank you everyone for joining, and thank you, Dr. Cates, for all the really valuable information. I believe that you guys are taking the summer off. Is that right? From the grand rounds and coming back in the fall, right?
Yes.
Okay. But remember, if you have questions, reach out at bladdercancer@jhmi.edu.
Have a great day, everybody.
Bye, everyone.